All right, let's talk about Module U, mental health and mental illness. We are going to explain the roles in nurse aid in the de-escalation of the resident who is agitated. We're going to describe anxiety disorders and mood disorders. So, of course, mental health is a resident's ability to cope with and adjust to everyday stresses in a way that society accepts. So, of course, something happens, we adapt and overcome, everybody's happy. With mental illness, there is a disturbance in the ability to cope or adjust to stress. Behavior and function are impaired in the cases such as mental disorders, emotional illnesses, or psychiatric disorders. And of course, the term de-escalate is the cause for something to become less dangerous or difficult. Of course, the key to de-escalation is a great day-to-day relationship with the resident. I've mentioned that in a previous lecture. It's important to know what is normal, so then you recognize immediately the signs that the resident is becoming agitated and can intervene before the resident escalates to the point to where you have a catastrophic reaction. That's the goal. So some causes of mental illness includes physical factors such as illness, disability, aging, substance abuse, and chemical imbalances. Environmental factors may be weak interpersonal or family relationships. Maybe this person didn't really learn these coping skills. They don't know how to interact in a way that would be considered appropriate based on society's standards. There may be traumatic past experiences such as abuse, things like traumatic brain injuries, PTSD. These may be part of what's going on. They may be inherited. Some mental illnesses can be inherited. They are genetic, such as true bipolar disorder. That is actually a genetic disorder that some people have to deal with. And they just may not have the ability to cope with stress. They can't handle it. It becomes overwhelming very quickly. So then they show signs of mental illness. Let's talk about a couple. Anxiety disorders. Okay. Generalized anxiety disorder is characterized by anxiety and worry in the absence of an imminent event or threat. So they're worried about things that haven't happened yet or things that may never happen, but it's consuming them. Obsessive compulsive disorder is characterized by obsessive behavior or thoughts, which may cause an individual to repeatedly perform a behavior or routine, such as washing their hands over and over and over again. OCD, things have to be in a specific order. Things, if you move something just a little bit, that can cause them extreme anxiety. OCD usually is a control thing, like they feel when they do these repetitive motions, it's giving them control over their environment. Post-traumatic stress disorder is brought on by experiencing or witnessing a traumatic event, such as violent crime or combat in the military, which we're obviously seeing more now, and we are recognizing it as a true anxiety disorder. Phobias are an intense irrational fear of an object, place, situation, such as flying, heights, fears of spiders, and things that you may come in contact with on a regular basis, or there are some out there that don't make sense to us, but they make sense to the person who is dealing with the phobia. So we don't ever downplay the phobia as when we're taking care of somebody. So those are generalized anxiety disorders. Mood disorders, such as depression, may cause a loss of interest in activities that somebody may once have enjoyed, such as eating, sleeping, or working. The individual may suffer intense emotional or physical pain. And of course, if left untreated, depression can lead to suicide, especially the older adult who feels like they've got nothing else to do. Bipolar disorder is the condition in which an individual has mood swings and changes in energy level, including the ability to function. So they swing from being extremely active, that's their manic phase, to the other period of severe depression, which is where they don't do anything at all. Like they fall into these deep depressions and can't be motivated to do anything. And of course, then there's schizophrenia, which interferes with an individual's ability to interact with others, make decisions, think normally and clearly, and communicate with people around them. Individuals who experience, some of these people experience hallucinations, which means they may see or hear something that's not really there. They may be having a conversation with somebody that they believe is fully present, but we cannot see or interact with. These individuals also experience delusions and may believe that other people are trying to control their thoughts. This may be why they're wearing the aluminum foil hat or helmet. Again, we don't downplay the fact that these are real to them. We do try to ground them in reality, but we don't ever downplay the fact that this is, that they aren't actually seeing them, because in their mind, they really, really are. Of course, treatments for mental health or mental illnesses, medications come into play. We have a lot of different types of antidepressant, antipsychotic medications that have come a long way and are very, very effective. Psychotherapy, this is where you talk to somebody. You have a therapist, you can talk about your fears and learn coping skills, learn how to handle the different stresses and anxieties that come up on a day-to-day basis, or even the random anxieties. You need to work to that point. And of course, there's cognitive behavioral therapy. You're learning what to do and what not to do, things that help you feel in control that aren't going to then take over your life. You learn how to react to things. And of course, when dealing with mental illness, you want to do a combination of those three. One alone isn't as effective as a combination of two or more. Of course, it's important for the nurse aide to recognize inappropriate behavior and report those to the nurse, and de-escalate the behaviors. If you see them start to happen, because you want to get the behavior under control before somebody gets hurt. And of course, the nurse aide has many chances to observe and get to know the resident, so you would know what their triggers are more often than the nurse. You'll know what the appropriate responses are that will help to de-escalate the person, because you do have that great day-to-day relationship. And of course, it is important to know that the first and only objective in de-escalation is to reduce the level of intensity of the resident's behavior so that a discussion can then become possible. It's not the role of de-escalation to solve the problem. That is not the point of de-escalation. It is to reduce the intensity of what's going on, so then you can now have a conversation with the resident and then try to figure out what's going on. When you are de-escalating a resident, it is very important to act and look a certain way, because if you feed into the escalation, if you feed into the behavior by being agitated yourself, then you are not going to be helpful in the situation. So behavior for the nurse aide, make sure you appear calm, centered, self-assured. Even if you're not, fake it. Fake it to the best of your ability, because your anxiety can be felt by the resident, and then the resident can then escalate to aggression. So you're going to want to appear calm, collected. You are in control. You know what's going on. You're going to fix this problem. Your posture, try to always be at the same eye level. Like I said, you are going to want to, if they sit down, you sit down. If they stand up, you stand up. You're going to want to be relaxed and alert. You're not going to want to put yourself in a position where you may be able to be caught off guard, i.e. don't turn your back on them. Stand up straight with your feet shoulder width apart and evenly balanced, so you can move in whatever direction you need to in order to make sure you stay safe in the situation. You don't want aggressive stances. Don't fold your arms over your chest. Don't hold your hands up in front of your face, because they may take that as an aggressive stance. Position yourself for safety. Never turn your back. Always maintain a distance of at least 2 arm lengths. Don't get close enough to touch the person, because if you touch them, they can touch you. So always maintain the 2 arm lengths. If they move towards you, you move back, which is why you always want to make sure your back is to the door. You can always get out. Place your hands in front of your body, down by your side, in an open, relaxed position, because it appears non-threatening, but your hands are available to block should you need to. If a resident hits you, you are not allowed to hit them back. That is not allowed. If you are the person who, well, that's just my natural reaction, you're going to have to get control of that. You cannot hit them back, because then that becomes assault, and you are then now guilty of it. So if they hit you, you can't hit them. If they swing at you and you block them, that is allowed. That is defense, but you are not allowed to hit them back. Your body movement and language should always be calm. Okay, if you show anxiety in your body movements, then they will then feed on that and become more agitated. So you want to make sure that you don't pace or gesture, don't fidget or weight shift, don't cross your arms, don't punch your hands in your pockets because then you're not available to you. Don't put your hands behind your back for that same reason. They can be interpreted as a negative body language, but then it also opens you up for attack. Don't point or shake your finger at the resident. That is obviously going to probably increase their agitation. We don't touch them unless we have specific permission to touch them. And there should be a very good reason to have to touch them if they're bleeding. You're going to want to get permission and gain control of the situation before you then start to treat whatever may be going on, because if you touch them, then they are close enough to touch you. But we want to make sure that we keep everything non-threatening and non-hostile. Maintain a neutral facial expression. If you're someone who has a hard time with that, this is a good time to practice it. No eye rolling. Make sure that you're not showing any sort of negative facial expressions such as grimaces or frowns. Always be calm, attentive. These kinds of expressions can reduce hostility. And of course, when it comes to eye contact, you want to let them know you're paying attention, but you don't want to stare them down. When we say limited eye contact, you're going to glance up, look at their eyes, and then look away. You may be able to look at just their earlobe or watch their mouth while they're talking, but you're not going to want to stare them down. It's not about maintaining direct eye contact for extended periods of time, because then that can be viewed as an aggression, right? That can be viewed as an aggressive stance on your part. But you don't want to not make eye contact with them at all, because then that can be interpreted as you don't care. So glance up, make eye contact, and then look away, to their ear, to their mouth, or to their chin. You're still maintaining facial, but you're not trying to stare them down. Because of course, excessive eye contact can appear to be as a threat, whereas no eye contact can be a rejection of what they're saying. Oh, I've already done that. Trust your instincts. If de-escalation isn't working, stop, call for help, get somebody else in there, back away. You definitely don't want to let it escalate, okay? Oh, let me go back. My book and the slides off. We talked about eye contact, attitude. Let's talk about attitude for a minute. Refrain from becoming defensive. Even if they're calling you all kinds of crazy names, things you've never been called before, don't defend yourself. You don't have to then try to prove them wrong, or don't defend yourself. Don't even try to get in the middle of that conversation. It doesn't even warrant a response. Be respectful, even when setting limits, okay? The individual who is agitated is going to be very sensitive to feeling shamed or being disrespected, so you don't want to do that. And of course, the resident needs to know that it's not necessary to show they have to respect you to get respect back from you. So you're always going to want to maintain their dignity. And obviously treat all residents with dignity. Use a low, monotonous tone of voice. Keep it low. Don't get loud. Slow it down a little bit. Sometimes, when we get agitated or anxious, our voice level just goes up naturally. So you have to kind of forcefully slow it down and calm it down. And of course, if they're yelling, don't try to yell over top of them to get their attention. Just continue to keep that low voice and repeat their name. Try to get them to focus on what you're saying instead of you trying to overpower what they're trying to say. And of course, keep your voice obviously at an average volume. Respond selectively. If they ask a question you can respond to, respond. But don't respond to, the examples they give you in the book is, why am I even in this place? That's not something you can answer. That's not something you have control over. Other than to say, we're here to take care of you. We're here to make sure you're safe. If they're, why is everybody in this place a jerk? You don't need to respond to that. What's your response going to be? I know everybody here is a jerk. Well, then now you're probably going to make it worse. But if you start to argue with the other direction, not everybody here is a jerk. Yes, they are. Now you're in a fight, right? So you don't want to do that. Be honest. You don't want to lie to the resident, because of course lying will then break the trust, and then you've got something going against you for future escalations. Well, you said that the last time and you lied to me, so why should I believe you this time? So be very, very, very truthful. I cannot do that for you. We are not able to handle that. I don't know why this is happening. Be okay with not knowing or not having the answer. I can't answer that question for you. But don't volunteer things that may also upset the resident. They may hate the food. The food in here is terrible. I'm sorry you feel that way. That is an appropriate response. You're acknowledging what they have said to say, yet you're not agreeing with them. Reasoning. If directed by the nursing care plan, explain the limits and rules in a firm tone, but with respect. They may not understand that. You may have to do it 3 or 4 or 5 times. If you can give a choice, make it a reasonable choice. Okay, you would, would you like to go for a walk and have a conversation? Or it's not going to, are you going to calm down or am I going to tie you down? That's never going to be the response you give, because that is going to escalate everything. So you want to make sure that you want to make sure the options that you give them are acceptable options for the resident. They might want to go for a walk. They might want to go sit outside for a minute, listen to nature, whatever you can do that might help calm them down. Empathize with their feelings. I understand you have the right to feel angry, even if you don't understand, but you can set limits while you do that. The example in the book says, I understand that you have every right to feel angry, but not okay for you to threaten me or the rest of the staff. And that is an appropriate statement to make, because it is not okay. It is okay to set those limits. You can suggest an alternative. Would you like to take a break and have some water or some coffee? You can give them an option to take a deep breath. Sometimes all you have to do is break the flow, and that can help de-escalate the situation. We're not trying to analyze their feelings. Again, we're not trying to give them a solution. We don't want to argue, and we want to list the consequences of the inappropriate actions, but we want to make sure it is not a threat, okay? We don't want them to feel like that they are getting ready to be in trouble because of their reaction. And of course, sometimes you have to tell them what the limits are of the facility. This guy may be like, why can't I go get in my car, and why can't I just drive to the store? I just want to go to the store. Well, sir, we don't have your car here. And you don't have a driver's license because of safety reasons. You can tell them exactly what the truth is, but they may not like that answer. Just to let you know. So, but again, trust your instincts. If it's not working, stop. Get somebody else in there. Call for the nurse. Call for help. Always control your environment. Maintain 18 inches. Maintain your feet shoulder width apart. Move out of harm's way. Remove objects out of harm's way if possible. If your resident can grab it and throw it at you, pull it away. Try to get it out of their way. Try to get it out of their reach. Watch the client without touching them and try to keep them safe. If you have to move other residents, then move other residents to keep your person safe. Look for meaning in the behavior. Try to be the detective. Try to figure out what's going on. Address the feelings, not the words. I'm sorry you're angry. Not, I'm sorry you called me a mean SOB. Try to look at their body language and facial expressions. Sometimes I can tell you whether they're winding down with their escalation or whether they're just getting, they're just ratcheting up higher and higher. And of course, given what you know of the resident, what might the behavior mean? This is where the good day-to-day relationships come into play. Check for the underlying cause. Sometimes they're hungry. Sometimes they're uncomfortable. Maybe there's physical pain. There may be emotional triggers. The resident may have been startled, and that's what led to it. They may be too hot or too cold. They may have had a change in their schedule. Sometimes that's all it takes to have a resident escalate is you change their schedule, or expecting this for dinner and they got something else. They were expecting a cheeseburger and they got chicken. Respond to the person's reality. Obviously, try to redirect their attention. Explore the triggers of the behavior. Try to figure out what caused it so you can hopefully avoid it in the future. Engage in the resident's story. Ask what's been going on lately. So what have you been dealing with lately? You seem to be dealing with a lot of stress. What have you been dealing with lately? See if you can get them to explain what's going on. Of course, if the resident is upset about something that you can't control, their family hasn't come to visit. Well, what were your kids like when they were growing up? What was it like when they were little? Try to redirect their attention in that regard and get them to talk about the what's going on with them. Of course, we don't ever refer to the residents as their diagnosis because they are more than their diagnosis. It's not Alzheimer's guy in 15. Mr. Smith who has Alzheimer's. Again, it's not the lady with bipolar disorder who's in 12. So, everybody has a name. Everybody is individual, regardless of whether they have a mental illness or not. And they have a unique background and life experience. And not everybody has the same mental illness. Not every person with bipolar disorder reacts exactly the same way or has the same behaviors when they go manic versus when they have depression. Same with schizophrenia. Not everybody has the exact same thing. So it's important to understand that we're dealing with a set of possible behaviors, not a set of behaviors. You can know people. I worked with a guy who had bipolar disorder, and he'll tell you he was a very angry gentleman for a long time until he got on medication, and he was just as calm as could be. But he still had bipolar disorder. He wasn't cured because he found medication that helped him control his bipolar symptoms. He simply had control of his symptoms at that point. So effectively communicating day to day is what really gets you through. It helps you get through the escalating times. Of course, all behavior has meaning, so looking for the meaning behind the behavior is key. The resident may not be doing these things on purpose. They may not really understand what's going on, so you have to try to find the trigger with them. You can successfully handle the situation when a resident is stressed and agitated by using proper communication skills. And of course, when unusual or inappropriate behavior escalates, everybody may be in danger, including the resident. If you know of triggers and you know of things that help de-escalate, you're going to want to communicate those so they can be put on the nursing care plan so everybody can follow those same skills and techniques and to hopefully work for everybody. The day-to-day relationship is the most important tool to use when the residents are agitated. So keep that in mind. All right, that is the end of Module U.